I think we'll be starting in a couple of seconds. All right. So good morning, everyone, and welcome to our international panel of mental health, culture, and compassion. I am Professor Ligia Milan Perez. I am English professor for the Department of English and Foreign Languages at the Pontifical Catholic University of Puerto Rico. And it is my honor today to be here with you, moderating this event on such an important topic, which is mental health. We are very excited to have you today as our virtual audience. And we hope that everyone is and continues to be in good health, in good spirits, despite this global pandemic that we are all living in. This event has been organized by 3 higher education institutions: Mohammed First University in Oujda, Morocco, Clarion University in Pennsylvania, United States, and the Pontifical Catholic University of Puerto Rico. This event will be recorded and it will be uploaded on the YouTube channel of the Pontifical Catholic University of Puerto Rico. Sadly, due to some reasons out of our control, this event will have no interpretation. So we want to apologize if this is an inconvenience for any of you in the audience, all right? We want to acknowledge some of our professors that are here today. We want to acknowledge Dr. William Noggle. He has been the link between our nations. Dr. William Noggle is the head of the Foreign Languages Department at Al Hussein Technical University at Jordan, and he was part of the Clarion University faculty. We also want to thank Dr. Amy Salzgiver, Director of International Affairs and Multicultural Education at Clarion University. We also want to thank Dr. Said Mentak from Mohammed First University in Oujda, Morocco. He could not be here today because, well, academic responsibility sometimes, not sometimes, always goes first, right? We also appreciate the work of Joel Vélez Colón, which is the Executive Director of the International Office Affairs of the Pontifical Catholic University of Puerto Rico, and also Dr. Ilia Rosario, which is Interim Dean of the College of Behavioral Sciences and Community Affairs at the Pontifical Catholic University as well. And finally, we want to give thanks to our 3 panelists who I will be presenting right now. We have Dr. Ana Plaza Montero, Professor of Psychology at the College of Behavioral Services and Community Affairs from the Pontifical Catholic University of Puerto Rico. Dr. Ana Plaza Montero has a doctorate degree in philosophy with a specialty in clinical psychology from the Pontifical Catholic University of Puerto Rico. In addition, she has training in mindfulness and EMDR therapy focused on trauma. She has a certification of therapeutic counseling in addictions, certification of pediatric psycho-oncology, a certification in health psychology, certification in hypnotherapy, another certification in cognitive coaching and integration seminars between psychology, anthropology, and spirituality from the La Universidad de la Mística. She currently serves as Associate Professor at the College of Behavioral Sciences and Community Affairs and as Coordinator of the Clinical Internships. She also facilitates courses in the Master's Program in Integrated and Applied Neurosciences at the Pontifical Catholic University of Puerto Rico. Welcome, Dr. Ana Plaza, and thank you for being here.
Thank you.
Now we have Dr. Bushra Onaib. Dr. Bushra Onaib is a professor of psychiatry at the Faculty of Medicine and Pharmacy at Mohammed First University. Dr. Bushra Onaib is a laureate of medicine and pharmacy from the Mohammed Fifth University in Rabat, Morocco in 2008. From this university, she earned a diploma of medical specialty in psychiatry in 2012. Since 2016, she has been an associate professor in psychiatry at the Faculty of Medicine and Pharmacy of Mohammed First University in Oujda, Morocco. She is a holder of a doctorate degree from the Center for Doctoral Studies in Life Sciences and Health in the Epidemiology and Affective Disorders. She has published articles in this direction as she teaches psychiatry, psychosociology, and health psychology. Welcome, Dr. Bushra. We're very happy to have you here today. Now we have Dr. Mark Lepore, Director of the Clinical Mental Health Counseling Graduate Program from Clarion University in Pennsylvania, United States. Dr. Mark Lepore has earned a doctorate in counselor education and supervision from Duquesne University. He holds a Master of Arts from Duquesne University and an MSW from West Virginia University. He also has a clinical social work license, a professional counselor license, and 5 education certifications. Dr. Lepore is currently the director of the Clinical Mental Health Graduate Program at the Clarion University at Pennsylvania. He has worked as a school counselor, where he had extensive experience in helping refugee students and families with acculturation and mental health needs, and has shared his expertise in supporting the refugee support program at the Jewish Family and Children's Services in Pittsburgh. And Dr. Lepore has written about this work and insights gained in journal articles in the Journal of Pennsylvania Counseling Association in making connections, interdisciplinary approaches to cultural diversity, and in the Journal of Psychology and Brain Studies. Dr. Lepore areas of specialty include crisis and trauma, grief and loss counseling, and school counseling and consultation. He is a mental health trainer for the American Red Cross Volunteer Director for service to the armed forces, serving both in the United States and internationally to assist service members and their family with transitions, and has volunteered for assignments after the terrorist attack after September 11th, Hurricane Katrina, California wildfires, and many others. His team of mental health professionals wrote a curriculum that is used extensively by the United States Department of Defense, both nationally and internationally, to assist service members and their families as they reintegrate back into the community. He was appointed by the governor to the Mine Families First Respond and Communication Advisory Committee to assist minors and family members experiencing this crisis. Dr. Lepore also provides consultation to agencies, schools, and corporations where disruptive events occur within these organizations. Dr. Lepore, it's an honor to have you here with us today as well.
An honor to be here. Thank you.
Thank you. So now we will begin with our first presentation from Dr. Ana Plaza Montero from the Pontifical Catholic University of Puerto Rico, and her topic is on perceptions and statistics of mental health in Puerto Rico. Dr. Ana, you.
Thank you. It's an honor to be here with all of you, and we share the presentation with 2 great graduate students in psychology, Mr. Manuel Melendez and Jennifer Cardona. An honor to be here with you. Okay. Our theme is Perspective and Statistics of Mental Health in Puerto Rico. For start, it's important to acknowledge what is mental health in Puerto Rico. About the according to the law. According to the law, is the state of well-being resulting from the functional interaction between the person and his environment and the harmonious integration in his being of several factors. When one or more of these factors is affected, the person begins to experience a series of alterations in the state of well-being. This alteration in the past 4 years has been a constant with the experience of 4 major disasters. Starting in late December, a series of earthquakes devastated southern Puerto Rico, forcing thousands to take shelters on the street, in their cars and government tents as their homes were destroyed. This situation left people on the island traumatized. At the time, many Puerto Ricans were still trying to recover from the shock of hurricane, and then COVID-19 has only added to the trauma, as population with a high proportion of underlying health issues live in fear of getting the virus while also dealing with the economic impact of the pandemic. Seeking both healthcare and community support network more difficult and complicated, even as the mental health crisis caused many people to self-medicate with drugs and alcohol, and then shrinking economy has led to fewer drugs and alcohol treatment options in Puerto Rico. Many of Puerto Rico residents have developed mental complications by the present pandemic, as well as previous natural disaster. An economic depression that has been affecting the island for roughly 14 years are detonators for immediate mental health problems like depression, anxiety, and then increase the suicide rates.
Thank you, Dr. Plaza. In that same line, in terms of the suicidal behavior, it's a subject with a special relevance here in Puerto Rico. The Puerto Rico Health Department reported that after the hurricanes Irma and Maria, back in 2017, the suicide rates increased by 30% compared to the same month in the 2060. Also, all these problems, issues, and events provoke that the suicide is the third leading cause of violent death in Puerto Rico. In general terms, from the 2000 and 2020, we got a decrease in the death by suicide in Puerto Rico. We are over 6,000 across the years. It's also that this problem of suicide led the deaths of 8.2% per death of 100,000 persons by year. These are roughly 200 deaths by suicide over the years. Also in Puerto Rico, the poverty has serious implications in the availability of and quality of mental health services. These two subjects of interest, like the suicidal behavior and poverty, affects all the population. In fact, most of that population that affects is the children and youth. In Puerto Rico, in a study revealed that in 2019, 58.3%, or almost 6 out of every 10 children in Puerto Rico live in poverty. Of that percentage, 23% of our children are suffering anxiety because of the disasters, and 12% present a lack of concentration in the school. Also, 19% of our children experience fear in their homes. Also, another study back in 2016 evaluated the symptomatology of mental health in students from the 7th grade to senior year in both private and public school in Puerto Rico. The study revealed or reported that the 50.7% of the student has symptoms related to attention deficit with a hyperactivity disorder, Also, a 13.4% has experienced major depression symptoms. 8.3% has experienced suicidal ideations, and 6.9% represents with symptoms of a behavioral disorder.
So in the same line, the available mental health services are not enough, and further investment and evidence-based interventions are required to manage the mental health crisis. In the face of all this, our emotional vulnerabilities have been heightened. Compañero, ¿te falta una parte de discutir?
No.
Ok, que estoy viendo la presentación. No veo, ok, ahora sí. So following Hurricane Maria, Puerto Rico is working to address its increased rates of suicide and mental health issues. So now we have a collective issues of mental health that is being compounded by the lack of resources like child care, the fear of getting infected when leaving home. Also, we believe in camaraderie, but we do have a mental health problem in this time, okay?
In a response, according to the slide, in response of the public policy of the government and to manage and bring some tools to lead with mental health issues, we have the Health and Anti-Addiction Service Administration. This agency, this government agency, provide and state the psychosocial first aid line. This line is designed to help people with a high level of distress, anxiety, suicidal behaviors, any fear, any concern. By the last year, this service that provide the government of Puerto Rico across the past line of the psychosocial first aid line was increased substantially. Over the past year, more than 300,000 persons called to the line to receive assistance. It is very interesting that with the pandemic of COVID-19 was the most transit of calls that these lines received, with a number of calls of over 70,000 of calls. In the last year, this line received in between 1,070 to 1,800 calls daily. This is very interesting, but in other years, this line could be received in daily basis only 200 to 300 calls in a day.
In other words, the mental health professionals perceive that Puerto Rico is experiencing a mental health pandemic. Throughout history, the development of Puerto Rico mental health services have been influenced by the cultural, social, economic, and political development of the island. As we revise history, the evolution of mental health services, we can identify events or circumstances that hinder their achievements and the elements and actions that must be maintained, improved or modified so that progress is made and errors are minimized. However, the statistics that estimate the prevalence and incidence of mental disorders are not up to date, nor do they conglomerate to services provided by government and private agencies. Okay.
Another fact that states can go back to that. Thank you.
Okay.
Another fact that we have in Puerto Rico is that we 7.3% of the population of our island, or the adult population of our island, met the criteria to have a serious mental illness. And this is a very severe problem that we have as a nation. Most of the people have these thoughts that they don't need to seek help in terms of the mental health. The most frequent reasons for not receiving treatment is by two major thoughts. Was the problem will get better on its own, and they wish to handle the problem on their own. And this is a very cultural and social bias in terms of the mental health in Puerto Rico. In the same line, most of the mental conditions or mental disorders that are developed in Puerto Rico across the population as are mood disorders, eating disorders, personality disorders, use and dependence on alcohol and drugs, and suicide behaviors. Most of the relevance of these, we got that the anxiety disorder is the most common disorder affected our people. Affects the 5.9% of adults in Puerto Rico. Also, the mood disorder that compound depressions and bipolar disorder were the second most common disorders and affect the 4.3% of the population. And the other problem that we have and issues in terms of our mental health is the psychiatric disorder and co-occurring with substance use disorder. It's estimated that in Puerto Rico, the 50.5% of adults has a psychiatric disorder and a co-occurring with a substance use. There are another 40% of our Puerto Rican people who suffer for severe mental illness do not receive treatment of any kind. This study confirmed that thousands of Puerto Ricans battle with serious mental, emotional, or behavioral conditions daily. Many of them in silence without any kind of access to treatment.
So the investigations indicates a high incidence of mental health problems, limit access to treatment, present an impact of a stigma of people with mental illness, their attitudes toward seeking services, and the lack of prevention and treatment services for children and youth with mental illness. So mental illness conditions are associated with the presence of an illness that interferes with the person's ability to take care of themselves. Many communities' response to mental health needs and mental health condition varies and are influenced by factors such as stigma and discrimination associated with the mental health conditions, the inequity in the distribution of specialized human resources for mental health, and the modest financial resources to increase services. According to the mental health experts in Puerto Rico, two major themes or subjects. The first as is an emphasis on the concept of mental illness and treatment geared at a person with a mental health condition. In the second place, the existence of the poorly integrated mental health delivery system with fragments efforts at different points on time. Usually, a diagnosis of mental health condition is often aligned with a stigma that is perceived by the mentally ill person with feeling of rejections, loss of status, discriminations, being stereotyped, and loss of power. And that is an important point. So research with island Puerto Ricans suggests that a stigma toward mental health conditions exists and is strongly influential on the utilization of mental health services. Because of stigma, persons may deny their symptoms, avoid treatment, and suffer unfortunate consequences on their employment, relationships, and recovery process. The stigma does not only exist with identified patients and families.
Also, often the health professionals are biased and endorse mental health stigma. Health provider stigma is one of the factors that can negatively influence health-seeking behaviors and utilization of mental health services. This is a very, very, very important point because the social and cultural influence that has a person with suffering a mental health, a mental disorder is very influenced by the perception of others. And we are right now dealing in Puerto Rico to provide better services trying to mitigate that stigmatization across the mental health. By this, approximately 4 in 10 adults between the age of 19 to 74 years old meet the criteria for a serious mental illness did not receive mental services. Also, in Puerto Rico exists 4 factors that affect mental health services utilization. In first place, we have the community. Most of the community have the problem to identify and has the specific knowledge to deal with all the issue that the mental health disorders and mental health illness provide. Also, the health system in the way that is in Puerto Rico, the government health system is privatized. Most of the services that we got to the people are limited. Also, with the providers, in terms of the stigmatization that they have toward the mental illness, and the patients, because of all this cultural and social influence, they delay or they ignore to seek for help in terms of his mental health. Another important thing that we got in Puerto Rico has developed a very robust network of mental health facilities for all levels of care. But because of all that problems, social problems, economic problems, that services has a lack of accessibility to the people. But in fact, more of our mental health services in Puerto Rico are moving toward to try new paradigms in treatment, to maybe transform our mental service provider.
These situations is not invisible for the university. The community actions that the university accomplish include the community service offer interdisciplinary clinic of community service, office for management of loss, bereavement, and grief, and the school of caregivers of the elderly. Service doing with humanistic and sensitivity. In this service exemplify the Pontifical Catholic University mission, the commitment to forming responsible and professional men and women with the different disciplines capable of assuming positive role with the external community. We try and we range the effort to assist all the community. And this is our mission. Thank you.
Thank you very much. I want to acknowledge Manuel Melendez and Jennifer and Dr. Ana. You all did a great job. It's very interesting, right, to see a reality of a collection of data of all the hardships that as an island we've been through, right? We know, but we don't, when we see it here in a PowerPoint presented, like, wow, we've been through a lot. Okay, so thank you very much for such a beautiful presentation, and thank you.
Thank you.
Gracias.
Remember, everyone, that if you have any questions or any comments, you can type them on the chat, and then later on towards the end, I will be repeating the questions, and we will be answered. All right. Thank you. All right. So now we have Dr. Bushra Onid, all the way from Morocco, and her topic is going to be, what about depression and primary health in Morocco? All right.
Hi, thank you so much. It's a pleasure to me to be with you in this cultural panel, to share with you my experience in psychiatry in Oujda. and also to see the progress what you do in Puerto Rico and in Pennsylvania. At the beginning, I want to speak about the organization of the healthcare in Morocco. This is the second slide. It's divided in 3 levels. Okay, the first level. Can you show? Thank you so much. The first level, where there's a consultation center with a psychiatric, or there is a medical psychologic center. I don't know if you have the same in Puerto Rico, because it's the same thing we have in France, here in Morocco too, or in the center about addictions, or in private cabinet. For example, I know many general practitioner, physician who treat depression, for example. And in this level, physicians have to diagnose some disease like depression, to take care about these patients, to prevent recurrent depression, for example. If there is a problem, to refer to the second level. In the second level, it's about a provincial hospital, where there is a unit in psychiatry where they can hospitalize some complicated patients. They had to manage these complicated cases, and the emergency and psychiatric emergency. If there is a problem, to orient it, to make an alteration to the third level. The third level is essentially a university psychiatric hospital, where they can hospitalize patients with very complicated cases, or there is a unit for addiction, for hospitalizations. And also there was a consultation for psychiatry of child and adolescent. And some regions of Morocco, there is no level 2, just one level 1, and they have to refer to the third level to take care about these complicated cases. Unfortunately, in Morocco, there's no much psychologist. For example, where I work, in Wajda, in the hospital, there's one psychologist, just one. About psychiatrists, it's about 400 psychiatrists for all the country. They exist mainly in the big cities like Casablanca and Rabat, and they are dispersed in the other cities of Morocco. These psychiatrists have to make diagnosis, to identify risk factors and complications. They have to prescribe the drugs, to do psychotherapy, and they have some social intervention. According to the World Health Organization, the program, the World Health Organization for depression, is to diagnose and screen depression in the primary health care, especially in the countries where they don't have enough number of psychiatrists and psychologists, like Morocco. Also because it's the first contact of the patients in the system of healthcare. Please, the third slide, is possible. Thank you. So if we will have a look at the rates of depression in the primary healthcare in over the world, we will see so different rates numbers. For example, a very low rate of depression in primary healthcare in Japan, Nagasaki, where it just 2.6%, and very high in Santiago, for example, in Chile. I think it's a little far away from Puerto Rico. It's about 30%. The same in Zambia, in Africa, in center of Africa. It's about 30%. In Europe, we will see different rates. For example, so low in Verona, in Italy, it's about 5%, and high in Manchester, in Paris, between 14 and 1700%. So my work was, I want to know to have an idea about the rates and the prevalence of depression in primary healthcare. That's why I conduct a study. It's a cross-sectional study in three centers of primary healthcare in Morocco, in 2 cities, Wajda and Saleh Rabat. So it's made for 2 years, between 2012 and 2040. And I want to assess the prevalence of depression in primary healthcare. So it's according to statistic because in 2005 they made a cross-sectional study in general population of depression, other disease, mental disease. They found that the prevalence of depression in Morocco in 2005 it was about 26%. So according to the number, I have to assess about to recruit more than 300 patients. Please, the 14.5 slide. Yeah. So what I want to note in this study, just the first thing, they had to assess the prevalence of depressive disorders among this population. And the second thing, the characteristics, the socio-demographic characteristics of this population, the clinical features of depression among this population, the suicidal ideation planification, and also to determine the predictive factors associated with depression and suicidal ideation. So for this study, we used some scales. For example, the mini interview in psychiatric to assess depression, dysthymia, according to the DCM fourth edition, not the fifth edition, and also to evaluate and assess the gravity and severity of depression and the suicidal ideation planification. Also, we check for, we search for some socio-demographic characteristics like the level, the socioeconomic level, like the genital activity for women, and also the we evaluate also the social function of this population. Please, the other slides, it's possible. The other ones, I already told about this one. Yeah, the second one. Okay, in this criteria, how I choose this population. Okay, in these three center of consultation, we will take all patients who have over than 80 years, adults, for any type of complaints, and they agree to participate in the study. And we exclude from this study all people who know already for a psychiatric pathology, for depression or schizophrenia or bipolar disorders and others, and a problem of addiction, like, for example, problematic use of alcohol, others, and also the other population who has a chronic disease like diabetes or others. Why exclude this population? According to many studies, and we know this in our practice, these people who had a chronic disease, organic or psychiatric, for organic, they have often a problem of psychiatric disorders like depression or anxious. So I want a population who looks like normal, who came for the center of consultation for any complaints, for example, a pain, and we will see if these people had a comorbidity, have a problem of depression disorders. Yes, it's possible. Other slide. Of course, we take the approbation of the committee of the ethics committee in Rabat, University Mohammed V. Yes, please, other one. As I already told, so for this population, we determine the socio-demographic characteristic, the genital activity in a woman, the reason for consultation, if they come for pain or other things, or perhaps from sadness. We to assess depression, like the dysthymia or recurrent episode depressive or recurrent depression, and the suicide idea planning attempts. We use the mini interview, psychiatric, no psychiatric interview, and to assess the impact of the depression on the social function of this population, we use the global function assessment scale. Yes, thank you. What we find. So we recruit almost 400 consultants in primary care who are aged more than 80 years old, who looks good. They don't have a chronic disease. And we found among this population, they have almost 50%. They present at the moment of the interview, the time of the interview, they have depressive disorders. Almost 12% of them, they have current major depressive episodes, and 3% were dysthymic. And almost 80% of them, they have recurrent depression more than 2 episodes. And when we calculate the lifetime prevalence of depressive disorders was estimated at 8.5%. So it was a little high, what I suspect to found like prevalence. Yes, the other slide. Thank you. And in this population, almost 7%, they have a family history of psychiatric disorder, of depression, or anxious disorders. 3.4% then again they consume cigarettes, and the reason for consultation of this population was pain. 70% cases. I want to notice that no one patients of this population who have depressive disorders consult in this primary health care for sadness or for loss of pleasure. All of them consult for the reason of consultation in the moment of interview was another things, like example for pain, headache, or infections or others, but not for depression. Yes, other slide, please. The depression was more prevalent among women. There was the same thing for the current depressive or dysthymia, with a significant difference with the p inferior than 0.01%. Yes, other slide. Yes. Okay, I'm checking the clinical features of this population. The reason to decide the clinical feature of this population is to determine some characteristics for general practitioner. It was easy to diagnose depression in this population. We found that all of them have problem of sadness and the loss of a pleasure and idea, but the majority of them complain about somatic symptoms. We found the psychomotor retardation in 28 patients, the asthenia, but few less in concerning the cognitive symptoms, and for example the problem of loss of value, loss of hope was so less than somatic symptoms in this population of depressive people in primary health care. Please, the second slide. Okay, for suicidal ideation, for depressive patients, it's about 36% of them, they thought about suicide. 20%, 7% of them, they planned to commit a suicide, which is not such easy thing. And in the truth, 1 of 2% attempt to suicide. And according to the mini neuropsychiatric interview, 3.5% had a severe suicide risk. And no one of them complains about this to the general practitioner. And we will see how they react to the general practitioner in this situation. Please, the second slide. Okay, for the functional of this population, all they have so poor social professionals functional. The people with depressive symptoms and the pain, suicidal ideation, and severe symptoms, they have a so low social functional. Yes, and there's a graphic, I think. Please, the second one. And this graphic, yes, demonstrates the difference of planning of the assessment function social on this population, which is so low in depressive disorder, in 65.8% on this population. Please, the second one. Yes, I also studied associated factors and predictive factor associated with population. We find essentially the gender. It's more prevalent among women. Also, it's more among women in we have genital activity. It's associated with profession. Also, it's associated with the pain. Please, other slides. We explain. Yes, for gender, how can explain this associated? Indeed, we found a problem in this population because women were more individuals who consult primarily health more than men. That's why we have also this important rates in this population. Also, perhaps there's the sexual hormones can play a role in this depression. Also, perhaps of social norms. For example, in my culture, men they have shame to speak about their feeling if they feel sad, loss of hope, not like women which more easy to express about herself. For the age, we found that the middle-aged population who are more likely to have a depressive episode in this population. The limits that this category of age who consult more frequent, more prevalent the primary health care more than young people. Also, the people who are separated, divorced, widowed are more likely to have depression than people who are married or single. Please, other slide. For professional occupation, in our study, we found that people who work who are more risk to have a depression. Perhaps the stress of the work, perhaps the condition, the nature of the work can cause a problem to this population. For the level education, we found here the literate people who are disposed to develop the depressive disorders, but there's a problem, there's no distinction between the different level of education when we make the study just literate or illiterate, but we didn't make a correlation between the mood, depressive disorders, and the level of education of this population. But in the literature, we found sometimes the people who are in high level of education are more predisposed to make depression, and sometimes we found the people who are illiterate who are have more risk to have psychiatric disorders, especially depressive disorders. Please, other slide. Okay, for the clinical features, what you found in the literature? For example, we make a comparison between the clinical features of my population and the population in India. We found it's so near the characteristic. There are people more expressing pain, somatic symptoms than cognitive symptoms. But for example, in a population like Sweden, we found so different results. We found that people express more sadness, feeling, loss of hope than somatic symptoms. There was a big study made by World Health Organization. They compare the expression of depression around the world, and they found indeed that in some cultures, in some countries, people express more by their body or by the pain more than expressing their feeling or the cognitive symptoms, and not like people in Europe, for example, or in North America, who they speak more about their feeling. Please, the other slide. For the pain, okay, this is the problem here for me. In my practice, I know that many people with depression, they complain about pain. But when we see the classifications, for example, the DCM or the CMDs, for example, we make in Europe, we don't find the pain one of the criteria to speak about depression. In this population, we don't know is this a condition which make a risk factor of depressive disorders, or it's one of symptom of depressive disorders, and it's make a source of ignorance of this pathology of general practitioner. We will see, please, the other slide. We will see that for recognition of depressive episode in primary health care, in my sample, no one was diagnosed with depressive episodes by a general practitioner. Perhaps the expression of depression is so different. I know this people, and these people who are included in the study, no one of them complains directly about the sadness and loss of interest. Perhaps because they feel shame, they are worried of stigma, or perhaps they will say to themselves they handle on their own, and they can treat by themselves these symptoms. That's why they didn't complain about this. And even for the physician, they don't have the reflect to search about depressive episodes among this population. Please, the other slide. Okay, this no recognition of depressive disorders by Geneva Pakistan is not specific in Morocco. In the whole of the world, less than 50% of patients are treated for depression in primary health care. In some countries, less than 10%. Why? Because this is the lack of source. We know that Geneva Pakistan, they have to manage with diabetes, hypertension, problem of kidney problems. They have rheumatism problems, infections, health mother, health child. So they don't have easily this reflect to search about depressive episodes or to screen for suicidal ideation. They are not training enough. And they have a social stigmatization associated with mental disorders. Okay, there's many physicians are worried from people who have mental disorders, and they have a very poor assessment of this population, and many of them are not treated. And when they arrive at the hospital, a psychiatric consultation, they are all the time, many times, in advanced stage, which make treatment and the management of these people make more time and need more energy. Okay, other slide. Not just my publication about this study, just what I want to say at last. Indeed, in World Health Organization, they make a program for people who have depression to be screened in primary health care, but they have to take into account there is a specificity for every depression in the countries. The expression are not the same. This is true. This is the big criteria to lead to diagnosis this depression, but sometimes the expression is not the same, and this is the source of lack of recognitions, and many of them can be untreated, and they are exposed to the severe consequence like the suicide. And thank you. Okay, thank you so much.
Thank you, Dr. Bushra, on this great presentation on some of the, gives us an insight of how other countries are going through depression and how everything affects. And even though we're worlds apart, we still have, sadly, this in common. Okay, so now we have Dr. Mark Lepore. Dr. Mark. Hi. Okay, so Dr. Mark Lepore's topic is smooth seas don't make skillful sailors, turning stress into resilience. The virtual floor is all yours, Dr. Lepore.
Thank you so much for turning over the virtual floor. I appreciate that. And I really did enjoy hearing from my two co-presenters about the issues in Puerto Rico and Morocco. And I really did have the privilege of being in both of those places and taking graduate students and learning a lot about their approach to mental health and the humanitarian way in which they go about doing that. So I was also struck by the fact that there were so many similarities between the mental health issues there and the mental health challenges that we're experiencing as well. So I did want to talk about some of that, and I also wanted to talk about the way that we're trying to approach and deal with the onslaught of so many individuals who are experiencing mental health symptoms. And so I called my presentation, Smooth Seas Don't Make Skillful Sailors. And okay, it would let me share this, that would be nice.
How can we help you, Dr. Lepore?
I'm going to just go to another screen where I think I'll be able to share. There we go. There's always another way to go about this. Can you see that screen now?
But we can't see it in full. So remember to click on
Right.
the bottom from beginning. There you go. There you go. Perfect.
Okay. There we go. All right, we're rolling now. So when looking at what we determine to be a mental illness with individuals, what we go by is the Diagnostic and Statistical Manual, which I know Morocco and Puerto Rico you use as well. And what it says in that manual about determining what's a pathology or a disorder is looking at those very things that they talked about in Puerto Rico that were so prevalent, like mood disorders and anxiety disorders and co-occurring disorders, were experiencing those same types of things. But what they do, like if somebody is experiencing anxiety, what separates like the general population from experiencing a lot of anxiety and when it becomes a disorder is the type, intensity, and duration of the symptoms, right? So we could be in the process of experiencing anxiety or be in the act of depressing at certain points in our lives. And then at other points in our lives, we might be okay, right? And but what separates it is if that anxiety had gone on for a period of 2 to 4 weeks, and the intensity was so much that we couldn't participate in the regular activities of our lives. And so what we found out is that there are a lot of individuals that are experiencing a lot of anxiety, but maybe they don't quite meet that level to be diagnosed with an anxiety disorder. And so there are many, like right now, I know in Puerto Rico, they have called it a pandemic. We haven't gone as far as to label it a pandemic yet, but I do believe it is one. I think we're so overwhelmed by COVID and the pandemic of COVID that we haven't gone around to saying, yes, we actually have a mental health pandemic that's also occurring. So, but we do, because we've had a steady increase in the amount of anxiety, especially with younger people and college age people. That's been going on for many years. But now in the past year, it has really increased exponentially. So we're also struggling to find ways to help people regain their equilibrium. And so one of the ways that we're spending a lot of attention and resources on looking at the impact of trauma on individuals and how they are kind of acting out that trauma and trying to regulate that trauma as part of their lives. And so that's been part of our approach. So in order to augment or to increase the amount of clinical services that we're offering to individuals, we are trying to use community-based options. So we still use a lot of clinical, we use a lot of medications to treat people, we have a lot of therapeutic applications, but we're also, like I said, looking at the impact of trauma and trying to normalize it for people. And just like my co-presenter, Dr. Onabe, was saying, one thing we found is that females tend to be able to talk more about what they've been through in terms of crisis. And we have seen that that's been a protective factor for women. Men tend to struggle with that a little bit more. Perhaps it's due to stigma and other cultural factors that keep them from fully expressing that. But we know that it's, potentially an issue. So one of the things that we found when we're helping individuals deal with trauma and deal with crisis is that, each crisis is different in some ways. And when you say each crisis is different, what we're saying is when somebody experiences a crisis, they might talk about what it meant to them. And then other people will have a reaction to what that crisis meant to that individual. But on some level, when an individual experiences a crisis, they automatically go back to other crises they've experienced in the past and what that crisis has meant to them. And people will do that on a cognitive level, and sometimes it's on an unconscious level, but they automatically go back to that. So that's why we know it's important to make sure that we look at how trauma is impacting each individual. And this is a model that we're looking at, and we call it a post-traumatic growth model. And so when an individual experiences a stress or a trauma, like what we've been going through with COVID-19, they will bring to bear whatever coping mechanisms that they have available to them. And those coping mechanisms are designed to restore balance for them in their lives. Now, at that point, what the goal is for an individual is to go back to that level, that homeostatic feeling of being back in a sense of equilibrium. So the trauma knocks people off their equilibrium, puts them in a state of what they call disequilibrium, right? And it changes you, right? When you deal with a trauma, I think all of us going through this past year feel that we've been impacted in some way, that we've been changed in some way. And, maybe some for the negative, maybe some found some positives through that situation, but it's transformational in that way. And then some of those individuals, then when they're going through that trauma, will succumb to the stress. And we've seen that with individuals, and I think that really accounts for a lot of the rise in mental health disorders that we're seeing in people. So they succumb to the stress. Their natural coping capabilities have been overtaxed, so they can't handle it, right? And so they tend to stay in a certain place and not be able to get back to that state of equilibrium. And that's where we come in as mental health providers, that we can help them with that. Now, some people, in response to the trauma and stress, click in positive coping mechanisms. They may look for opportunities outside themselves to cope. And that actually helps them actually grow through the traumatic experience. And so that's what we talk about, positive post-traumatic growth, that it does offer that opportunity for people to bounce back, but even potentially in a better way, in a more efficient way. And so that's what our model is looking at. That's what our community mental health model is focused on right now, because we have so many individuals who are falling into these categories, that we need to have a model to look at it. And one of the models that we've spent a lot of research and time on is looking at the resiliency model and this idea of psychological resilience, which we're all familiar with. But what we've learned about resilience, we tended to think about resilience in a way that said that you're either born resilient or you don't have it. But the fact is that we can bolster resilience. We can learn to be resilient. We can provide resources that offer people the opportunity to build their own personal resilience. And so we've learned about that through several studies that we've done. And we know that that can be done. And we also know the benefits of tapping into that resilience for each individual and offering them what they call, they'll sometimes call them either developmental assets or protective factors. And so if we provide more of those developmental assets or protective factors for people, the better chance they have of becoming resilient and overcoming whatever challenge that they're having to deal with in their lives. So these are just some ways. I'm not going to go over all of them because a couple of them we're going to talk about later on in the presentation. But these are ways to build resilience, and these are ways that we as helping professionals can help people who are struggling with trauma or crisis or COVID-19 or whatever they're dealing with in their lives become resilient. And helping them make connections is a big one. And looking for opportunities for self-discovery, I'm actually going to talk about that because that really speaks to that whole model of post-traumatic growth that we were talking about. And a lot of times when people are going through a crisis or trauma in their lives, they tend to feel bad about themselves. They tend to, feel a lowered sense of self-esteem during that period of time. And so what we want to do is to help them nurture that positive view of themselves, maybe be a little bit easier on themselves than they're tending to be. Because, we can have a lot of compassion for other people when they're going through crisis. But then when it comes to ourselves, we tend to think, why can't I go over this? Why can't I do better than I'm doing right now? And so that kind of, people can get stuck. That's one of the things that can keep people stuck, right? And so we can help them get through that by nurturing a more positive view of themselves that might help push them towards that post-traumatic growth that we're talking about. And then, you know, we've been talking a lot in our professions, obviously, about self-care, about taking care of ourselves, because that becomes really important when we're focused on helping other individuals and taking on their problems. We can experience compassion fatigue. So making sure that we take care of ourselves becomes a real fundamental aspect of what we need to do. Now, this next chart is looking at individual protective factors that help foster resilience. And so there's 16 of them listed here, but obviously there can be more. But if you think about this yourself, like each one of us going through some type of challenge in our lives, what we tend to do, we tend to fall back on certain things that help us overcome whatever that challenge is. So if you look at this list, you know, relationships and service, all the way down to perseverance and creativity. Look at them and pick out 3 things. What are the 3 things that you think that you go to when you're under a crisis in your life or something that you have to deal with? What are the things that you fall back on first? Because we all do it. And so what we like to do is, when we're helping people who are experiencing these challenges, are to be able to name and label these strength-based things that are going to help them overcome their challenge. Because that's one thing we learned about mental health treatment. You know, I agree with some of the data that was shown that stigma is a real mental health issue. That is keeping a lot of people from seeking out help, and it causes a lot of lowered self-esteem for people. I agree with all of that data that was presented. So what we're trying to do is present it in more operational and functional terms for people, and also go to a strength-based approach. Because what we know for sure is, by concentrating on all the things that are wrong with people, and we tend to do this when we do clinical mental health, we tend to laundry list all of those issues that people have. And sometimes there can be 7, 8, 9, 10 things sometimes. And it sometimes looks overwhelming, you know, but what we know is that the only things that have helped people get better are by concentrating on what's right with them, not what's wrong with them. So if we can also look at what are these protective factors that individuals have in their lives that are going to help them overcome these challenges, then we know we have greater success in helping those individuals get better. So this is one way we do it, is we label it. Like, and maybe there, like if you look at these 16 things, there's probably 50 things, right? But you look at these 16 labels, and it helps you to start thinking about, what are those things that I have that are going to help me overcome challenges now? And this is a chart that we use sometimes, where if you're trying to, you could even start with yourself. You're thinking about, what is my challenge in front of me right now? And then you list the challenges, and then you list the strengths on the right side. And ultimately, when we started doing this, we'd have like 10 or 12 challenges, and we'd have 3 or 4 strengths. And then the goal now is to have, you know, maybe to have 6 or 7 challenges, but then we have 8, 9, or 10 corresponding strengths. So that's kind of the paradigm shift in how we're looking at mental health and mental health treatment. And it's been pretty successful. And the other thing we're doing in terms of normalization and activities, like we're doing a lot of mind and body techniques to help people. And we still use, you know, medication and that type of treatment, but we're also branching out into using mind and body techniques, like I said. And what we found too in our mental health treatment is that over the years, if clients or patients have been utilizing mental health treatment, they've really come to see themselves as being less empowered. Like they start to believe like they have to use the mental health system to get better. Like they don't have their own sense of self-efficacy. They start to lose that over time. So what we want to do is to bolster their ability to have tools that they can use so they can start to believe in their own self-efficacy, that they have tools, they have abilities to overcome their challenges. They can still utilize the mental health system, but that it's going to be self-empowering as well. So there are really literally hundreds of activities that we can do with people. You know, we do guided imageries, we do breathing exercises, meditations. This is what they call the gratitude exercise. And so one of the things we might ask a person to do, if they're so inclined to want to do this, is to wake up. You know, did you ever wake up in a bad mood in the morning? I think all of us have done that from time to time. And so what we're asking people to do is to write down on a Post-it note 2 things that they're grateful for when they wake up, even if they wake up in a bad mood, 2 things that they're grateful for that day. And then they go through the day. When they come home at night, write down 2 more things that happened that day that they're grateful for. And we ask people to do that like over a 2-week period. And what we've seen reported from people was that this has really changed their thinking. So it goes from that kind of pessimistic thinking to being a little bit more optimistic. So this is just one thing that we would use. There's so many different activities. As you all know, there's a lot of things you could use, but we're having a lot of success with helping people gradually turn around their thinking. So according to our model or our paradigm of looking at post-traumatic growth, what we ask people to do is to stay open to the fact that there might be opportunities for discovery in looking at the pain that they're going through. Like, what can they learn from that pain? Because one of our cultural imperatives in the States is that pain is bad. Pain is to be avoided. And if you're having pain, take a pill. If you're still having pain, take another pill. So we've come to really say that pain is the enemy. And of course, none of us want to be in a lot of pain. But the thing is, when we have pain, physical and emotional, it's really there telling us, it's our body telling us that there's something we need to learn about our situation. So what we want to do is we want to help people spend a little bit more time thinking about it that way. So it's an opportunity for discovery. And even having gone through traumas and tragedies and hardships in your life, what can a person potentially have gained from that experience? So it's about looking at it a little differently. And, you know, that's not going to happen overnight. When a person's in a lot of pain, you know, sometimes they can't see beyond their pain. And I don't think anybody says, boy, I hope I have a lot of pain today so I can really learn valuable lessons. None of us have really said that, I don't think. But there is that opportunity. And so as a mental health professional, we can use that opportunity to help guide a person to another place in terms of dealing with that situation in their life. And along with that idea is to consider what we call a growth mindset. So when we talk about post-traumatic growth, it provides that opportunity for us to think about things in a different way. So this is just a thought chart that we help people with. Like, you know, somebody might say, you know, I tried, I failed, I just can't do it. We ask them to say, well, could there be another approach or strategy that you could use? And so we just kind of offer alternatives for people to think about. And of course, each person's path is going to be a little bit different. So we're not going to try to impose our thoughts on them, but just offer opportunities for people to think about their trauma in a little different way. Okay, and then here's some mindset creation type strategies to try to embrace challenges. Sometimes when people have experienced a lot of failure, they just give up. So we're going to ask people to embrace more challenges and maybe try something. I've sort of felt this way for a while. I wasn't going to do anything I wasn't good at. But then I thought, okay, I need to branch out and try some things I'm not that good at. And then you find you're going to grow from those experiences. And then viewing growth as a process. So if we have failed, you know what we found out, if you kind of do some research into people who are extremely successful, what you found out is that they have actually failed more times than most people. But each time they fail, they learn from that experience. So we ask people to kind of think about things, you know, their failures as a stepping stone for them, and to try to have some tolerance for them having made mistakes, and to know that, you know, everybody can learn, everybody can achieve, but not in the same way and not on the same day. So we asked them to think about that as well. And then we talked about this idea of resilience, what goes into that growth mindset, and all of those other concepts that we talked about is this opportunity to develop resilience, or the ability to bounce back from whatever mental health challenge that they're dealing with now. And so just as my final slide, what we ask people to do when we talk about the fact that all crisis is related, we can ask them to focus on their past experience and see what strength, how have they handled a previous experience that might help them handle an experience now. And then to have them challenge the events that are in front of them and discover what they might learn from those difficulties. So that represents the approach that we're taking now. And a lot of it is trauma-based, because for years, I think we tended to not think about how much trauma impacted people. But now that we have research to back it up and we have a better understanding of trauma's impact, that's what we're thinking about a lot of times, especially in relation to all those things that my co-presenters brought up: depression, mood disorder, anxiety disorder, co-occurring disorder. All of those things have trauma many times, not 100% of the time, but many times have trauma as the backdrop. And so that's how we try to approach helping. And I will stop sharing at this point.
Dr. Laporte, this was excellent. And I agree with Dr. Jorge Macias that it's very interesting and great to hear from a psychologist that pain is not the enemy. And as a society, we've always been told that pain is the monster, and we have to learn how to work with pain to turn it into a positive outcome. And I will totally be trying the gratitude exercise to see if it can help me with one or two that I have. And William Noble said that he has used the gratitude exercise as well. It helped him a lot with a claustrophobia. So thank you, Dr. Laporte, for this great presentation.
You're welcome. Thank you.
All of our panelists for such an extraordinary presentations on mental health, on culture, and compassion. So now we have the question sections. I have some questions here for Dr. Bushra. Dr. Bushra, are you around? Is she here?
Yes, I'm with you.
Dr. Bushra.
Yes, I'm with you.
Dr. Saira Mateo asked a question, and she said that in the study, pain was subdivided in more specific areas. In the study, pain was subdivided in more specific areas.
Yes, we search for headache, chest pain, abdominal pain, and pain in spine, like this. Almost 6 areas of pain. Yes, that's true.
And I'm going to try and pronounce this correctly. Intisar Hadija, she asked you she wanted to ask you as well, is when you speak about pain, which kind of pain do you mean?
Yes.
Is it physical? Is it moral? Or is it psychological?
Physical. People are just speaking about physical. This is a source of confusion. Even with the psychiatrists, for example, in my country, sometimes people speaking about sadness, they say that just pain like here in my chest. And it's a source confusion. It's physical or more. But in this population, it was more physical.
Okay, thank you very much. Susan Glass
Thank you.
asked a question and made a comment, and I think this can be answered both by Dr. Busha and Dr. Ana Blasa. It's quite long, so I'm gonna pace myself so that you can both understand the question into its totality. So Sunglass wrote that there are many community-based programs in many community-based programs in PR or Morocco? Because she saw that the MH programs are offered through our Puerto Rican university partners. But what about Morocco? With the lack of professionals in the field, she imagines there is a great need for community-based interventions. Does this seem to be the trend, since it goes so well with the least restrictive environment model? Maybe you can both.
Okay, if I speak, yes, I try from Morocco. Okay, if I compare between my generation and the generation, actually recurrent generation now, there is a big progress. For my generation, they don't speak so much about mental health. Now there's many programs about mental health, suicide, depressive, and addiction. And for example, in a program for students in medical school, we spoke so much about depression and anxious, also during the training. And I can see, for example, for autism, I receive many children with autism who was screened with general practitioner or pediatric. There is some progress, but not to the level what we want. For example, here in depression, if the patient come to the general practitioner and said, I feel sadness, he will think about depression. But if it's different and there is more pain, physical pain, and for the patient complains about asthenia, it's not evident for the practitioner to see the depression. And this population usually come to the advanced stage.
Dr. Ana Plaza, if you would like to add something else. Do I need to unmute you?
Yes.
Yes, okay.
Thank you. Puerto Rico moved to a less restrictive model, okay? To a less restrictive paradigms. We use more sensitive, more compassion model, more humanity models. We try to prepare all the students with this model. We are a humanistic view, okay? But we recognize that's enough. We need more education, more professional education about mental health. Okay? But yes, we're more sensitive. If we saw the psychiatric and hospital and outpatient treatment, outpatient treatment is more efficient than hospital treatment. And we moved to this. And we moved to the health of the people. And we moved to the rural areas. Okay? We try, like Marx established, we believe in resilience. We believe in growth, that growth is a process.
Thank you very much, Dr. Busha and Dr. Ramaphosa, for answering these questions. Now I have a question for Dr. Mark Report. Question reads, after a year of pandemic challenges around the world, and considering your background with national initiatives to respond to natural disasters or other crises through mental health care, what are some recommendations for the improvement of our curriculums in counseling, psychology, or psychiatry from an international perspective? I get unmuted. Let me unmute. No, okay.
Okay. Wow, what a great question. And I've been a proponent of this for a long time. I really think we should try as much as possible to take a lot of the jargon out of mental health and mental health treatment. And I think that, as counselors and mental health professionals, we're the right people to do this, so that we can bring these concepts to a population of people without, the jargon, without the layers of language that separates how we go about helping people from people getting that help. So I really think that we should just make programs available that are accessible, that people can understand and relate to, and of course increase access, because that's an issue in the States right now. One mental health agency I know of right now, it's in a small rural area where our university is located, but they usually get like 10 referrals a month. They got 75 this past month, and it's been increasing that way. So the demand is there, but we can't meet the demand. So I think we need to go about increasing our psychoeducational approaches, that we can bring this knowledge about how people can get support out to as many people as possible. And I think that sometimes we're limiting ourselves when we're putting diagnosis on people, because that's a label that, as my co-presenters talked about, can be preventive in terms of people getting services. So I'm a proponent of taking the labels out, normalizing it, and getting that information out to people about helping themselves.
Thank you very much. I have another question from Dr. Saida Mateo. It says it's for Dr. Lepore or any of the panelists. So maybe Dr. Ana Plaza, Dr. Bushra, and Dr. Lepore can give their perspective on this question. The question reads, there is any related neurotransmitter unbalance in people who lack of resilience? Maybe we can begin with Dr. Lepore, then Dr. Ana Plaza, and then Dr. Bushra.
So, we've had like exponential advances in studying the brain as of late. And so we're learning so much about brain processes and how to treat that. And so that's another avenue of mental health that we're providing in the States, is neuropsychology. And so I think that there's always opportunities to learn more about that. And I'll defer to my colleagues if they know more about that specific neurotransmitter, but I know that's an area of research that's really increasing right now.
Dr. Ana.
Dr. Mateo, hi, how you doing? Some research correlate dopamine, serotonin, norepinephrine as neurotransmitters that incidence in the resilience experience. And in some limbic areas of the brain. But low serotonin, dopamine, norepinephrine, okay, may lentificar, okay, Ligia, en inglés. Sería mayormente poner más lento.
Like decrease?
Some degree of the limbic system. For N, on the frontal cortex, the frontal lobe action.
Okay. Thank you very much. And Dr. Bushra? I think she's having some technical difficulties. Okay, so I have another question from Intisar. She didn't specify to who it is, so maybe again we can go with Dr. Mark Lepore and Dr. Ana Plaza on their perspective on this question. Question reads, do you think that depression can be only a psychiatric disorder, or is it mainly due to any psychological unbalance?
And I'll defer to you first.
Okay, both are factors for me.
Wow.
Yeah, both are the factors, because depression have implications in the neurotransmitters, implication of the action in the brain. Well, it has some behavior that manifests sadness, suicidal risk, another way.
Okay. All right. Thank you very much.
And yeah, I would agree. I mean, I definitely think it's both. And with depression, obviously they see that there is a a lack of dopamine and serotonin that individuals are experiencing. But another way, like to put it in kind of behavioral terms, sometimes we can look at depression and say that depression is a lot of anger turned inward. So when people can't express that anger, they turn it in and it can become depression. And so one of the things that we look at, of course, we would treat it, clinically, but in conjunction with clinical treatment, we would also look at the fact that really an individual can't overcome depression by only concentrating on themselves. So one way is that they have to come outside of themselves and experience things outside of themselves. So I would definitely say it is both as well. Dr. O'Neill, did you want to say something about it?
Yes, about neurotransmitters. Okay, that's true. There's a big action of neurotransmitters on depression. We can't deny the effects of drugs on the elevated of the mood. Also, when psychologists or psychotherapy can do a very well psychotherapy, it has the same effects of drugs, but they need to be rigorous. So even psychotherapy has effects on neurotransmitters. So that's changed the behavior of the patients. But I don't know if there's a correlation between the perturbation of neurotransmitter and lack of resolution. I don't know if there's a study in this sense. Perhaps it will be. It's possible, but it's not easy to make the neurobiological study. It's a very hard things. The PET scan, and we are not sure what's happening in the brain. It's peripheric, or it's not so easy thing. So hard to do it.
Thank you, Dr. Busha. I have one question for Dr. Busha Onib as well. In 2019, an online survey conducted among 637 medical students from the Faculty of Medicine and Pharmacy of Rabat in Morocco evidence that very high rates of burnout were found among these undergraduate medical students at 93% and 68% reported, respectively, exhaustion and disengagement. This study showed very high levels of burnout among Moroccan undergraduate medical students. How do you perceive these high rates changed during the pandemic due to COVID-19?
This is a study conducted during the pandemic?
Yes, no, the year before, during 2019.
Okay, first of all, we have to say
how
how
the
the study
rates
was conducted.
Because the study was conducted in 2019, and we want to ask you if you think these high rates changed during the pandemic due to COVID-19. If burnout.
We can't say. I can't say yes or no. It's so hard to say it. Just we have to wait to see the impact of the pandemic. Now we are waiting the third wave. We don't know what will happen. Okay, even in the study when we see it, when we perceive it, the results, it depends how we make this study. It was online or it was direct. Which instrument was used? Is the student understand very well the questions? There is many bias, and also, for example, the survey in online, almost in big percentage, people who reply in survey who are concerned about the problems. Not all people will reply to the survey. Let's make the results. I don't know, not sure. But in this situation, perhaps these students are not prepared to meet the practice, because they are studying, they are in an amphitheater, they are protected by their teacher, but now they are in the real world. They have to practice. Perhaps it's the source of stress. Perhaps there's other factors. This is the limits of study. For example, my study now, when I see now, I can see there is many limitation. I didn't see it in the moment when I conducted the study.
Thank you. Perfect. Excellent. Thank you very much. William Nuggle asked, they wants to ask a live question, so you can go ahead.
Yes.
Hi, I just wanted to go back to Dr. Hadia's question about the psychiatric disorders and physiological imbalance. The reason I'm asking is from a very selfish and personal perspective, because I lived in New York for about 15 years, and I spent probably about 6 years of those, 6 of those years going through severe anxiety attacks. Prior to getting on the subway, prior to going to work in the morning. And, it took me a long time working with my doctor, and we came up with kind of like a two-pronged approach. One was that my blood sugar was dropping in the morning, either because I hadn't eaten enough or because maybe I had eaten something that I shouldn't have been eating, or maybe too much sugar or something. And so I was experiencing a change in my blood sugar level, and it was somehow affecting then my anxiety level prior to getting onto the subway, and then the psychological impact of, gee, I have to get on a crowded subway in the morning, and I was just it would just make myself more and more anxious. And so I guess as again from a personal perspective, and I'm kind of interested in this question about the connection between psychiatric disorders or mental health and physiological disorders. I mean, how often do you see that kind of connection between the two?
Well, I don't know. I guess I'll go first, William. It took a long time. I think intuitively we knew this for a long time, but the American Medical Association came out, now it's about 15 or 20 years ago now, but they said that 75% of our physical ailments were due to chronic stress. And so I think that's how prevalent it is. And, and the other thing we did in the States is we separated mental functioning and physical functioning for so long. But now we see how the two are intertwined in so many ways. So if you have a problem psychologically, it's going to impact you physically. And if you have a problem physically, it's going to impact you psychologically. So we really try to treat people more holistically now, knowing that there's going to be impacts in both areas.
Sorry, I can say something about the question of William.
Sure.
Yeah.
Okay, for example, perhaps this is your interpretation of the symptoms you feel. This is the real symptoms, but your interpretation, they see it like this is the anxiety. Sometimes we have these patients where they have panic attacks. They have, for example, the palpitations. The hearts will beat very quickly. Okay, for example, they were walking, they were running, but they not attribute this work of hearts to the effort. They see this is on the anxiety. This is something very bad will happen. Sometimes the psychological interpretation of the person of what he feels, that he makes these anxiety disorders.
You. Okay, perfect. So now I would like for the three panelists, if you would like to give your final thoughts on the overall experience of this panel. If Dr. Ana Plaza would like to go first.
Thank you. We hope we enjoy the talk, okay? And we need to know what you need for more experience like this. What are your expectations? And we can do the more effort to do it. Okay? And thanks for all the panelists. It's a great experience. Okay, and we have the first step for more injunction.
Thank you very much, Dr. Ana Plaza. Dr. Bouchoni.
I will take you. Thank you very much for Dr. Anna and Mark Lepore for this sharing. I would like to share also the information about Puerto Rico. It was so great to know the situation, the mental health there and their issues. Also, the resilience of the presentation of Mark Lepore was so interesting. I'm so glad to be with you. If it will be second step other time, I will be happy to be with you.
Sure will be a second time. Dr. Mark Lepore.
Well, it's been an absolute pleasure to confer with my co-presenters, and I think that there's so much knowledge to be gained in seeing how there are different approaches to helping people. And also, I've just been struck by the universality that's involved and how similar it is in terms of how we go about helping people and what the needs are. And so I really enjoyed being part of this. So thank you all.
Well, thank you very much, Jennifer and Manuel. I hope you enjoyed this experience. You both did an extraordinary job at presenting. So I want to thank everyone again. This was amazing. I hope that we can all get together for a second panel. And I would like to remind everyone that you will be receiving a survey in your email. So if you could kindly answer the survey, it's for input on the activity. And so when it's time to meet again, we can have, you know, we can have another extraordinary event. William, are you around? William, would you like to, since you were the connection between all of us, would you like to say some final words? We can't hear you. Wait. There we go. Now there you go.
That's probably the best way to approach me is to mute me. This has been amazing. Wow, what a great presentation, great presentations, great questions. Thank you so much. Well, and Ligia and Anna for hosting this event, and hopefully there'll be many more events to come. It was great seeing everyone and making these connections, because I think this is really important to know that we have friends out there all around the world.
We do. Yeah, we do.
Thank you all.
Very much to everyone. Have a great Thursday, have a great weekend, and God bless you all. Thank you.
Thank you.